Hello, Cannabis. You don't need coffee for this one. Thank you, Milton. It was a very timely conversation we had with you guys just a few weeks ago, and thank you for seeing the opportunity and letting us come down and do a talk. My name is Pradyum Sekar. I'm the CEO and co-founder of Sale Cannabis. My other co-founder's in the room as well, at the back there. So any technical questions later, I'm going to divert to him. Little background. Both of us have a background in primary care. We actually come from practice management. We spent the greater part of our career working outside of the cannabis industry, actually, with primary care, outpatient care. We are Canadian. We've always been in Canada, and that's where we started from, and that's where this business started as well. 2014, there was a big change in the regulation in Canada. Federally, they legalized cannabis for medical purposes. It was legal before that, but they changed the way it was being delivered. We came into the industry as consultants to help some of these producers understand how to market to physicians who are now the gatekeepers. And we came on a tremendous opportunity to be able to widen access for patients and physicians, which was a serious problem in Canada back in 2014, and is also a problem for really any market that's going legal in cannabis. So what is Sale Cannabis? So Sale Cannabis is an e-prescription. It's a point-of-care system that we built for physicians and healthcare providers to be used at the point of care when treating patients. The goal of Sale Cannabis and its e-prescribing platforms is to bring data-driven evidence at the point of care to help physicians be able to walk a patient through qualification, through understanding how to dose, understanding how to educate them, and being able to prescribe them compliantly within that regulated market. But then also as a tool that's available for patients to be able to understand the product, understand how it can help them, understand how to dose it, understand how to buy it, understand how to access it, and be able to bring both physician and providers into the same fold. So Sale Cannabis is a database-driven platform. We are evidence-based. Over the last 3 years of our platform, we have analyzed thousands and thousands of data points through prescribing behavior of physicians. We have a medical advisory board. We combine evidence data in the industry as well to be put into algorithms that drive these decisions for these guidance documents for physicians at the point of care digitally. So where there's a lot of information available through literature and research and conferences, there's a lack of this information available to providers when they need it in front of a patient within the time and window they're provided to consult that patient. So using some of these tools and platforms, we produce the ability for physicians to have this at the point of care. And the credibility factor is where evidence is still lacking from clinical trials, Sale Cannabis is able to fill some of that void in some of that evidence data that we're able to present to physicians. So like I said, so we're 3 years old. We're not a startup anymore. We're a grow up, not a grow up, a grow up. We started in Canada. We're now in the US. We're within 10 states in the US, primarily Eastern Seaboard. We have over 65,000 patients that have been processed through our system. And again, these patients are on an annual basis and growing as we continue to expand to new markets. So we all know about the Google patient. They come to you, they've researched, they've looked up their condition, and they talk to their physician about what potentially could be wrong with them. And maybe the physician is more so validating what they found and being able to provide them care. But that's okay when we talk about industries outside of cannabis, because physicians are well aware of what their patients want, what they need, and perhaps what information they should be having at the time when they make those decisions. So they're able to better educate them and take on those questions. Nonetheless, it's not always the best way for physicians to treat their patients, but the Google patient does exist and the physicians are okay with that. Cannabis is not the same though. It's been anecdotally proven for many, many years, meaning that patients have self-diagnosed themselves, they have used the product themselves, and they have a tremendous amount of knowledge that sometimes goes beyond the ability for a physician to have the same educated discussion they would have with them with any other condition or medication. Whether it's a patient who speaks to someone who's tried it in the past, or whether they're on support groups, there's a lot of information out there for patients to go and research. The source of that information is questionable, but there's a lot of information out there. Here's an example of some of the big social media sites that are out there that produce information for patients, and all go towards helping patients better understand the industry and better understand how to access it, and bring patients up to a place where they can perhaps advance the conversation with their practitioner. But the problem is advancing that conversation with the practitioner only works if the practitioner has that information. For example, we've all seen these kind of success stories. 8-year-old child with seizures or epilepsy. They've tried medications in the past. Those medications have had serious impacts on their health and conditions, and those medications haven't really shown much benefit. And then the patient finds a physician that's willing to trial cannabis, and that cannabis might be a CBD oil, and this physician may or may not be their primary care provider. And through the course of this medication, the patient sees drastic improvements in health. So much so that patients that were, given a timeline and not too far to live suddenly have, an opportunity to go beyond that, and you see these miracle stories. Now, in our conversations with our physicians, it's not enough, because these stories don't have enough behind them in order to help a physician understand why and what I can do to replicate that same situation again. And so it often can scare a physician too, and say, a patient comes at me with all this research and all this evidence to say it's going to help me and I want to do this, but I'm not willing to have that conversation with that patient yet because I don't know what I'm supposed to do. So how do you take an industry that has so much momentum behind it, driven by patients, enforced by federal or statewide governments to be served through a medical program, enabling physicians to be the gatekeeper of that industry to say, you physician must qualify that patient, and now have that physician actually follow through on that in a way that they've been used to in mainstream healthcare? We're not talking about a little traction, we're talking about a lot of traction. I'm sure everyone's been following the news on cannabis. If you're from California, California has, it's been going on for a while. In Canada, it's been the last 3 years. We're talking states in the US. There's now 29 legal medical states in the US. Australia, Germany, Colombia, Brazil. I mean, it's growing, and the number of countries that open up generally open up first as a medical program, and it all follows a similar pattern. So when physicians aren't able to have a discussion with their patient, there's a common trend that we've seen, and this is how we got into this industry back in 2014. In 2014, the old program for cannabis, the MMAR program, had 500,000 patients under it. When the new program in 2014 got released, what they called as the MMPR, which now made physicians responsible for the qualification of patients, the program only had 30,000 patients in it. And today, that number is still under 200,000. So what happens to the rest of the patients? Well, they're forced to go to other sources. So either they're home cultivating, they're going to the black market, and they're accessing products because they're not able to have a discussion with their physician or have support. And not all patients may necessarily qualify, you're correct, if that's a concern. But at the same time, without it, you're now helping physicians and enabling a market that in fact is potentially doing more harm than good. So we talk about telehealth in this industry, and I was asked to talk about how telehealth will fail or succeed in this industry, and I thought, well, let me take a little bit of a darker path to this. So telehealth will fail in the cannabis space. It will. It's going to fail because we don't have the basis for where cannabis needs to be as a medical platform today. Telehealth will work if you have the basis and you're able to enable that through technology. So the first thing is getting patients and physicians on the same page. The second thing is, once you have it on the same page, how do you scale it? And when you're scaling it digitally, you need to have the support of the industry to scale. And we've heard I've heard a lot today about how telemedicine has been blocked, how telemedicine hasn't been easily adopted by regulators, by physicians, by groups and associations, and there's no difference in the cannabis space. If you can successfully do telehealth, though, looking at the Canadian model in the cannabis space, telehealth will help the industry grow because there are a number of physicians still that are not willing to prescribe. And so rural populations of patients can now have access to physicians who are willing to prescribe. Therefore, you get to save the patients from going to unregulated markets. I mean, those are just some of the benefits. There's many more, but as we see the market growing, this is significantly going to help access for patients. So in Canada, even though it's federally legal, the provinces don't support or haven't supported it for a long time, which means that the regulatory bodies for the physicians will often say no. If they don't say no, they won't say yes. And if they do say yes, they won't say how. So here you have an industry with physicians who are told it's your responsibility. I'm not going to support you, but if you do it, I'm not also going to tell you how to do it. But if you want me to tell you how to do it, I'll give you some really vague guidelines on how to do it. And then I'll tell you what you can't do, like telemedicine, for example. So you have certain states like Ontario that can run telemedicine, but you can't do telemedicine from home So you need to do telemedicine through telemedicine sites. So it's restrictive. You have provinces like VSee where it's possible. You have provinces like Alberta where telemedicine is allowed, but not for medical marijuana. Why? I don't know. Because it's not yet fully understood. And so the first thing is getting regulators on board, and making them understand the benefits as to why this needs to go. Again, data. Everything's going to come from data and evidence, and we all know this. It's a new industry. It'll take years to come around, but when it does, the hope is that this will start to change minds. Billing is a big part of it. The way physicians are compensated, especially in Canada, cannabis assessment's 15 minutes. We're not allowed to bill privately for it. We have to bill it through the public health insurance. So you get 15 minutes to assess a patient for cannabis. It's nowhere enough in order for a physician to go through what they don't already know in assessing that patient. And it's kind of what at SAIL we're trying to do, is automate the entire process of a physician from qualification to prescription within 15 minutes, because we understand that this is a bottleneck in the process. And the same thing with being able to add the supportive tools at the point of care. We've all heard about the unregulated telehealth industry. This does not help. So if you're in California, you'll know that there's providers out there where you can call, answer 2 questions, and receive weed at your door in 45 minutes. Okay? You can't provide proper health care within that period of time. So while there is unregulated markets for telehealth, it doesn't mean that's a good thing. It just means that it's not empowering proper regulations. It's hard to understand. It's hard to get buy-in. In this industry where we're trying to cross cannabis into mainstream healthcare, if that's what we're really trying to do, it's time to treat cannabis as an actual medicine, which means employ the same requirements that's needed. Here's a trend of physicians, and here's where we see things going. So when we first started in this industry, the physician first would say no. So a cannabis doctor or a physician in Canada, for example, would say, "You asked me about cannabis, you're fired. I don't even want to talk to you. How could you even bring this up with me?" Okay? To maybe a few years ago where this physician would say, "I'm not ready to talk about it, but go ahead to one of these referral centers, they'll treat you." To now saying, "You're my patient. If I'm going to send you somewhere, I should be responsible, but I need to know how." And where we want this to go tomorrow, and if SAIL Cannabis can do its job well, our belief is that the doctor will say, "Happy to have the conversation with you. Come on in and see me." So right tools at the right time for physicians to get on the same page as their patients, we believe, will transform this industry. And really, telehealth at that point will be the channel, the vehicle in order to drive this thing forward. And we're very excited to have these conversations with Milton and his team at VSee. We do have telemedicine built into our platform, but like anything else, we're constantly looking at improving its application and its performance. But you need to combine telehealth with clinical data, with the technology, with the tools at the point of care, and that's really what we do believe. So thank you very much. I have to take questions. And no, I don't have any samples. That's what comes around. So.
Thank you for that talk. So a couple of comments / questions. So I mean, I think it's clear that by taking a process like this and standardizing it in a way where you're educating both sides of the equation, the providers and the patients, is the way to go. But at the same time, I guess my question to you is, so if we go down this path and we develop this infrastructure to provide for the patients and the providers, yet in the background there are market forces that are taking cannabis from illegal to decriminalized to now legal for medical marijuana, and then subsequently ending up in a market to be completely legal.
Yeah.
So my question is, and it's a concern as a physician, how do we prevent this dynamic from resulting in the same thing that happened after prohibition with alcohol?
So I think it's important, and we're learning this industry too as we go on. I believe there's 2 sets of patients, or 2 sets of cannabis users out there. There's those users that want to use it recreationally, and there are those users that want to use it medically. I can't say with exact percentages, but I can definitely say that more than 70% of all the patients that have been through the platform at any one of the physicians prescribed in the system are over the age of 55. Recreational users are not. And so when you end up with recreational users and a recreational industry, I don't think it's one or the other. I think it's this and that. And I think what medical users will look for will be different than recreational users and vice versa. Points of access, there's a lot of differences. So I think, as we build up the industry, you have to keep that in mind, that you have to keep both users' perspectives out there.
Delivery of marijuana between state lines, is there a problem in Canada? And the second thing is, how do you make sure that once you prescribe something, the end user is the person getting it and delivered on time and there's no mal-usage?
The first question, it is federal in Canada. Delivery is through mail order only, through the producers. We don't have storefront retail in Canada, legally speaking. But yeah, so federal, yes, it's okay. How do you know the end user is getting the product at the end of the day? It's a good question, and it needs to be considered for physicians. And so we also have patient-reported outcome tools in our system that allow physicians to track their patients and using it. But like any physician starting with cannabis prescriptions, we always say start low, go slow. So don't prescribe too much off the bat. Yeah.
I really liked your presentation. I think you're very credible, and presentation was great. Can you talk a little bit about the Florida legislation?
Yeah.
And is that a bellwether? Are we going to be seeing more of that in other states? Kind of what the root causes are and what.
So just some context on that question. Florida is the only state in the U.S. that actually so far replicates a prescription model for cannabis. Most states, a physician just recommends, meaning they register, and then the patient decides how much and when and what they buy. So patient education is crucial. Florida is the only state so far that has actually put a limit on how much patients can be prescribed, when they have to come in for renewals, what they can buy. So there's no flower in Florida, you can't smoke. And so it's exciting to see from a validated model of medicine that Florida...
So I think in the statute that they passed this session, they actually said that you can't use telehealth for cannabis. They made a special exclusion for cannabis.
They've been going back and forth on this. They did say yes, then they said no, and I can't tell you where it is now, but I do believe that now you might be able to do it for a renewal encounter, not for the first visit. It's still not fully solidified. There are states like Maine and Connecticut that are telemedicine, but not Florida yet, I don't believe.
That was a great talk. Thanks a lot. I was curious about any issues or hurdles you've had in the Canada area. We've been thinking about sort of expanding into Canada, and just from a telehealth perspective, can you give the U.S. Population here that is interested in telehealth some guidelines or rules to help us?
Yeah, every province is different. So for me, it would be, first advice is, Ontario, for example, if you're going to do telehealth, you have to go through the Ontario Telemedicine Network. It's like a monopoly, so it's very much controlled. Every state has a different regulation, and like anything else, telehealth is adoption. There's a lot of rural populations in Canada. There's a lot of benefit that comes from it, and you're starting to see a lot more of patient engagement tools, which I think is great to consider for when you're going out that way. But at the end of the day, it really comes down to adoption and EMR functionality and the ability to coordinate and communicate the two together.
Right. So you'd say go to the government websites, figure out what's allowed there.
Yeah. Well, not even the government websites.
Call
it's actually it's the college websites. Yeah.
Okay. Thank you.
Yeah.
Hi.
Hey.
Great talk. Just a couple of questions. How do you manage off-label use, if that's such a thing? Right. If you prescribe it for pain, or how do you ensure that that's what they're actually using it for? And are you doing any kind of cohort study that's actually showing efficacy at any level?
So we do have a patient-reported outcome tool that patients do journal. Of course, engagement on journaling tools itself is a challenge on its own, and I'm sure most people will face that who try and do that. But generally, you can dose cannabis based on strength. Again, every region is different. Like I said, in the U.S., it's not required, but in Canada, it is. And based on the profile of the product, you're only supposed to sell that patient what fits that makeup. So there's some control in some markets, not in all markets. And this is part of the challenge of sort of standardizing the process for prescription. Yeah. It's not like prescribing a regular medication. It doesn't require the same.
Hi, we've been reading in the news that Canada is close to legalizing recreational marijuana in 2018. Do you think it's going to happen? And if it happens, how it's going to affect the medical marijuana regulations? I mean, then we don't need gatekeepers. You think?
Yeah, there's mixed feelings about it. It is going to happen. I mean, it has been given a timeline, and I believe by July next year we will be looking at that model in some level of implementation. We don't know if it's retail or specifically how that's going to look across the country. How medical fares, it hasn't yet been detailed how the medical program will work alongside, but what we have seen is in Canada, like in Colorado, like in Massachusetts and Maine, a medical model will remain. There's benefits for medical that you just can't get recreationally. Think of over-the-counter versus prescription grade. Also insurance will come into play as well. And also we have some of our largest pharmacies like Shoppers Drug Mart that have now applied for distribution of medical marijuana through pharmacies. And so there's a lot of lobbying power for medical as well. And like anything else, we believe with recreational, you will empower physicians more because, again, it removes the stigma a little bit more, but also it removes the fear of physicians for patients who are just trying to pass recreational under a medical banner. So.
Quick question.
Yeah.
So from the federal perspective, obviously this is illegal. So how do you meet those obligations at point of sale?
Federal regulations in the U.S.?
Yes.
So we don't play in the point of sale system. Our platform is purely based on practitioner to patient and patient to practitioner and educating the patient on what's available out there. So we don't educate them on anything that's not regulated by the state. We don't actually work with them in any which way on the actual sale of the product, but each state has their own regulation for how they grow, how they dispense, how they sell. So I can't answer that specifically federally. I'm not in that space of cannabis, of the industry, but my rule is as long as you follow state laws and don't take the product outside, you should be okay.
Gotcha.
Can I ask you a question? How about, so you had a slide from the physician say like, no way to actually prescribing. So
yeah.
During that, did you guys do anything to try to accelerate that behavior change where you just let the time take its course?
We're trying to. So 3 years ago, our model wasn't exactly at the point of care. It was more so, a prescription order entry tool. And it's taken Canada since 2014 to today to get to the whole point of even some physicians now saying, I'm ready to consider it. But still, most of them will refer. Yeah. So our goal now is, having built the platform over these years, is to go into markets like, newer medical markets and be able to accelerate that process so it doesn't take so many years for it to get to that point. Yeah.
Great, thank you.
But data will drive it, so the more evidence, the better it'll be.
Excellent. Any other questions? All right, thank you so much.
Thank you, Milton.
Amazing talk, really insightful.